Hi everyone. I would like to welcome all of you to the Society of Skeletal Radiology Resident Education Club webinar. My name is Majid Chalian. I serve as section head of MSK Radiology at the University of Washington in Seattle, and I will be serving as the moderator for this session. It's wonderful to see many of you joining us today. I believe SSR Resident Education Club continues to be an exciting platform for learning and discussion, and also bringing together trainees and faculty across institutions who truly share a passion for musculoskeletal radiology. It's my pleasure to introduce today's speaker, Dr. Atul Taneja, who is a clinical associate professor at Florida International University and musculoskeletal and sports imaging specialist at Baptist Health, South Florida. Atul serves as team radiologist for multiple regional teams as well. Dr. Taneja has 17 plus years of experience with a strong background in medical education and research. His training includes a research fellowship at Massachusetts General Hospital. Dr. Taneja serves as editor and reviewer for leading journals of the field and is an active member of pretty much all the major societies of the field. With this robust background, today Atul will be talking about plantar plate tears and differential diagnosis for metatarsalgia, a topic that's highly relevant to our daily activity. I personally find the imaging requests related to this topic quite baffling. Sometimes I'm like, did we help with imaging or not? So without further ado, please join me in welcoming Atul. And Atul, I believe you can start. The floor is yours.
Thank you, Majid, for the kind introduction, and also I thank the Society of Skeletal Radiology for the invitation to speak to the Resident Education Club. So for the next 40 minutes and so, we're gonna talk about the plantar plate tears. I'll try to make it easy. It's not an easy topic, like Majid just mentioned. It brings a lot of anatomy, and it demands our careful attention and dedicated protocols, so we can bring the best of our knowledge to the reports. So plantar plate tears are a common cause of pain and deformities of the forefoot. In 1986, the expression crossover toe was introduced, and plantar plate has a major importance in the physiopathology and stability of the metatarsophalangeal joints, as we will see in the next slides. The MTPs, the metatarsophalangeal joints, they are synovial articulations. They have this condyloid or ellipsoid shape, and we can divide them into two groups. The first, or the greater MTP, where the sesamoids will distribute the load from the first metatarsal head and protect the FHL, the flexor hallucis longus tendon. While differently, the second through fifth MTPs, or the lesser MTPs, the joint has direct connection to the plantar plates. What I'm trying to say is that the greater MTP has its own anatomy. I'll show you a little bit about that today. And compression forces are higher in the second MTP, and then they decrease along each ray through the fifth. Plantar plates are fibrocartilage made, just like the TFCC, the menisci, the labrum, meaning they should be dark, they should be black in all sequence. Remember that. And the fibrocartilage at the plantar plates, they are disposed in a longitudinal aspect, and their composition is very similar to the menisci. And what do they do? The plantar plates, they support the traction in the longitudinal axis, and especially the compressive load of the body through the metatarsal head. So they are very, very important to the stability of the forefoot, and especially the stability for each toe. They have two main connections. So the proximal aspect of the plantar plates are made by loose synovial tissue. It's more flexible, while the distal attachment has a firm aspect and at the base of the proximal phalanx. All right, so loose in the proximal aspect at the metatarsal head, and then a firm attachment at the base of the proximal phalanx. And they have other multiple insertion sites. They can attach, they can have some insertion sites to the plantar fascia, collateral ligaments, transverse intermetatarsal ligament, interosseous tendons, right? So let me show you the greater MTP first. The greater MTP has the medial lateral sesamoids, and between them, we're gonna see the intersesamoid ligament. And from the sesamoids, we're gonna be able to check for two main components. One is the sesamoid metatarsal ligament, and another one, the sesamoid metatarsal ligament, and another one is the sesamoid phalangeal ligaments, both for medial side and also on the lateral aspect. This is an illustration that shows beautifully lateral sesamoid, medial sesamoid, intermetatarsal ligament, and then the sesamoid phalangeal ligaments. And what happens when there is an injury to the first MTP? These are the so-called spectrum of the turf toes. Turf toes, they are related to these capsule ligamentous complex injuries, and there are a lot of degrees of lesions from ligamentous strain, sesamoid fractures, or even dislocations. So in this lecture, I'm gonna focus more on the lesser MTPs, okay? But I just want to show you a case on a turf toe. 28 years old male patient that was presenting with pain 2 days since 2 days after an NFL match. What we can see here is a proximal retraction of the sesamoid, a torn sesamoidal phalangeal ligament. You can see it's detached from the sesamoid. A lot of edema, contrast enhancement. And also on the short axis view, we could see the sesamoid metatarsal phalangeal ligament torn. You guys can see a very easy looking defect. So this is what is called turf toe. Now let's move and switch gears to our lesser MTPs, which I'll be focusing more in this lecture today. The lesser MTPs, they have an important role in stabilizing the MTPs. I mean, the plantar plates have an important role in stabilizing the lesser MTPs as an static component, also along with the lateral ligamentous complex. I'll show you in a bit, and the joint capsule. And also the MTPs are stabilized by dynamic components, which are the extensor and the flexor tendons and the interosseous tendons. Now, the plantar plate has this central location. Remember, I told you it's a fibrocartilage, has its central location at the plantar aspect of the MTP. Distally, they have this firm attachment to the proximal phalanx, and proximally, they have this loose attachment to the metatarsal neck and head. Let's see the ligamentous complex related to the plantar plate. So we have the plantar plate here in the bottom, and then we have the accessory collateral ligament and the proper collateral ligament. Plantar plate will have a greater relationship with the accessory, but also with the proper collateral ligament. The proper collateral ligament will insert at the metatarsal head and then attach to the proximal phalanx, while the accessory will insert at the metatarsal head and directly to the plantar plate, as we can see in this short axis view, accessory collateral ligament, and then up there, the proper collateral ligament. And below here, and making this this plantar aspect of the capsule, we're gonna see the plantar plate itself, overlying extensor tendon and flexor tendon. And again, like I just showed you, plantar plate, flexor tendon, collateral ligaments, and then now in blue, what I'm trying to show you here are the interosseous ligaments. So we just spoke about the accessory collateral ligament, proper collateral ligament, plantar plate, and now overlying the capsule, we're gonna see these elongated and thin ligaments, tendons, which are the interosseous tendons. They will come from the midfoot, the muscle belly, and then they're gonna go along each medial and lateral aspect of the MTPs. All right. And then what I'm also want you to remember is that the plantar plate has a very close relationship and attachment to these interosseous tendons. And what happens when there is a plantar plate tear? So this is a normal MTP. All the static and dynamic stabilizers that I just mentioned. What happens when there is a tear? So in this case, we see a tear, and automatically the proximal phalanx go subluxated dorsally. That's a normal movement because the proximal phalanx just lost his attachment to the plantar plate, and in addition to that, the interosseous tendon is still attached, pulling the proximal phalanx, making this deformity becomes even more strong. The deformity keeps from the acute phase to chronic phase, like as we see the hammer toe deformity, which means the metatarsophalangeal joint is extended due to this pulling force from the interosseous tendons, while the plantar plate has lost its attachment. And the plantar plate tears, they are distributed they are bimodal, they have bimodal distribution. They can happen in young adults, usually related to sports, in a traumatic event. And also, like I showed you, the first MTP, it's one of the most common injury, but all of them can be injured. And on the other hand, we have elderly women or middle-aged women that have plantar plate degeneration leading to tears. So we have this first group of young patients, traumatic injuries, sports related, and then the older group, degeneration and chronic plantar plate injuries. They can happen in any of the MTPs, but I'll highlight the second MTP as with the higher incidence of cases. All right, so more commonly, the plantar plate tears will happen in the lateral aspect of the plantar plate. So at the proximal aspect is going to attach to the metatarsal neck and head, but the distal aspect of the plantar plate that I showed you, it attached to the proximal phalanx. It has both medial and lateral attachments. All right. So it's more common to see the plantar plate tears in the distal insertion, meaning the phalanx, at their lateral insertion. Let's say here we have the short axis, normal anatomy, and this image in the middle here, we have a plantar plate tear, as we were seeing the MRI short axis through our views, and then we see a lateral tear. All right, this is the most common. But then the plantar plate tear can also extend to the ligament and to the interosseous tendon. Then what happens there? The other side is still stable while this side is unstable, bringing to the crossover deformities, and I'll show you. So this is a classic case. As I was showing you, we have a defect at the plantar plate at its attachment to the proximal phalanx. And when we see in the short axis, a defect on the lateral aspect of the distal attachment. So we have a classic second MTP plantar plate tear. And, and another case in a more chronic aspect where we see a lot of fat stranding, meaning scar tissue here, we still with some edema, some contrast enhancement, and we can see the defect, in this case, more towards the medial side. On the sagittal, it's really interesting because we can see the plantar plate in its longitudinal aspect, and then we can see the defect right at the proximal phalanx attachment. What causes plantar plate tears? Acute traumas, like I said, synovitis with chronic degeneration and erosion of the plantar plate, and mechanical overload, which is one of the most common causes, especially for elderly. And that's related to the chronic overload through the MTPs, especially the second and third. And there is also this thing that is called insufficiency syndrome of the first ray. What happens with the short first metatarsal and the hallux valgus deformity? All the the load will come to the second and third MTPs. All right, so these are the ones that are most injured. And the chronic use of high heels is classic, also a classic cause due to this chronic overload in the extended position of the forefoot. All right, so let's say we have a distal tear involving the lateral aspect. And in this case, I also will show you a tear of the capsuloligamentos complex and in its lateral aspect, let's say also involving the interosseous tendon. What's going to happen next? So we had lost the lateral support and the plantar support, but the medial interosseous tendon is still attached. What's going to do over the time? It's going to deviate the proximal phalanx to the medial aspect, and that's where we have the classic so-called crossover toe deformity. In this case, we see exactly like the illustration I showed you. The second toe has the MTP hyperextended overlying the greater toe, which is showing a hallux valgus deformity. So we have a classic crossover toe deformity. And this is a very severe case on the clinical examination, so easy to see. But we need to remember that we can see that on x-rays. We can see, even though they are very in the early stages, if we see a mild subluxation of the second or third proximal phalanx, just be careful, you might be dealing with a plantar plate tear. On x-rays, patient will present with acute, subacute, or chronic pain. They will have focal tenderness at the plantar region of or at the toe base, and they can tell you, I feel like walking on lumps, walking on marbles. So that's the feeling they have because the coverage of the plantar aspect of the metatarsal head is gone, and then they are stepping right at the tear, at the injury they have. Um, and on X-rays, also the hammer toe deformity due to the extension of the MTP. Differently from neuromas, the plantar plate do not tear injuries. They do not come with distal radiation of pain. That acute or chronic pain that patients that have neuroma present, they go distally, like like if it was electric shock to the toes. The plantar plate is more when walking. All right. So on the physical examination, the orthopedic surgeon and or the podiatrist can depict some movement and instability of the MTP, just like the drawer test for the knee, also the drawer test for the MTP, also the paper pull-out test or the apprehension test to check if there is still some strength in this toe or the strength is lost, so he could not hold the paper below the toe. All right, radiographs, like I was telling you, you guys need to be aware of the medial subluxation, which is more common. And in this case, easy to see the crossover toe deformity. You can even mention that in your report. But when when it's not that impressive, even those mild subluxation, especially if you're dealing with weight-bearing radiographs, which will be ideal, you should mention that in your report. On the lateral view, you can see the hammer toe deformity. All right, let's move to um, the approach to possible plantar plate tear if there is this suspicion. Old school type of exams like classic conventional arthrography, we don't do that anymore. We have MRI, but that it will be related to a dorsal injection of contrast with extravasation either to the tendon sheath or through the capsule or even to the soft tissues. That will mean there is a capsule injury, there is a plantar plate tear. Also, MR arthrography that were done way much more frequently before, they're not needed anymore. Why? Because we have high field magnetic field strength, high resolution images that we don't need to poke the patient, inject contrast, invasive method for a plantar plate injury, and I'll show you how easy to see on the conventional MR. So in this case, contrast was injected, and we can see the plantar plate injury to the lateral aspect with extravasation to the tendon sheath, just like I mentioned. Ultrasound is very interesting, dynamic. You can do with linear probes or ideally with the hockey stick probe. So you're going to have a more focused approach exactly to the plantar plate. How does plantar plate shows in the ultrasound? Normal anatomy, you're gonna put your probe, ideally put the patient laying his stomach, and then you go through the plantar aspect of the foot. This is the probe here, plantar aspect, and then you're gonna see the metatarsal head, proximal phalanx, and here you go, plantar plate. Okay, overlying the flexor tendon. Just remember a pitfall. Sometimes right at the proximal phalanx attachment, you guys can see a more echogenic, more white looking area. This is normal. This area where there is this firm attachment that I mentioned at the proximal phalanx, the collagen disposition can be more tight, and then it brings this artifact. It becomes more echogenic. It's not an injury. That's completely normal. And let's see a case with a plantar plate injury depicted on ultrasound. So we have sagittal views, metatarsal head, proximal phalanx, and then you have a gap here right at the plantar plate. The plantar plate is retracted, and you see now during dynamic movements, which dynamic movements, flexion and extension of the toes, easy to do. If you need some help, put the probe, ask for the technician or someone else to help you to move the toes easily and nicely, and then you can see the movement. You should not see a defect between the plantar plate and any of the capsular components, mainly to the proximal phalanx, all right? I think it's a repetition here. Let's move. Okay, so sagittal view or longitudinal view, transverse plane, and the same case on MRI, defect, proximal retraction, and a large defect on short axis, all right? How about ultrasound versus MRI as I go into MRI findings? Many studies have tried to compare the accuracy of ultrasound and MRI. Both are very good. You can use both in your routine. What studies have been shown is that MRI has higher specificity while ultrasound has higher sensitivity, but they are very comparable when it comes to the overall accuracy, all right? And let's move to MRI. This is the normal aspect of the plantar plate on MRI. Okay, longitudinal view, short axis view, plantar plate, collateral ligaments, and overlying, we're gonna see the interosseous tendon. Ultrasound, as I just showed you. And remember another pitfall, now most useful for MRI, which has been described in almost 50% of the patients, it's a normal recess. There is a normal recess of the plantar plate when it attaches to the proximal phalanx. And this recess, if we see on short axis view, it can even bring medial and lateral distension of this recess. They are very millimetric findings, but I want you to keep that in mind, and I'll show you in a little bit how to differentiate a recess from a tear. All right, let's start with the direct findings. Which are the direct findings for a plantar plate tear? The tear itself, the defect, as we can see here, a large defect of the plantar plate attachment at the proximal phalanx base, both on sagittal view, on short axis view, with the arthroscopic correlation. And what about the protocol itself? What protocol we need to assess plantar plate? You should use your regular standard protocol. One of the most useful, excuse me, one of the most useful sequences for assessing the forefoot is the T1, simple T1, no fat suppression. That's where in this T1, that's where we're gonna see clearly the fat plane that we should be seeing going into the intermetatarsal space being replaced by the neuroma. Okay, and then you can go for your T2 sequence to find the intermetatarsal bursitis or some vascular changes. And then if you have it, it's not mandatory, the contrast enhancement. Some papers have shown a good correlation between MRI with contrast and plantar plate injuries, that they can bring a little bit higher accuracy, but I'll tell you 99% of the institutions will not do contrast in a routine for a forefoot or a midfoot pain. But in my experience, I do think that contrast can be helpful, but it's not mandatory. All right, this has been also published. All right, let's move. Indirect findings, there are many measurements that can be done. One, I will not go into measurements, just be careful when you see metatarsal, first metatarsal shorter than second. Remember about that insufficiency of the first that I mentioned. Also, there are measurements you can do to check for positioning of the proximal phalanx, the MTPs. And one thing that I find it very interesting is the subluxation or displacement of the flexor tendon. That's a common finding. All right. You can go into Dr. Uman's papers. They're very interesting to learn more about plantar plate injuries and these indirect findings. And one of the indirect findings I would like to highlight is the pseudoneuroma. What is a pseudoneuroma? It's a pericapsular fibrosis, mostly happening to the in chronic stages. And this fibrosis, this scar tissue, it's going to infiltrate not only the intermetatarsal space, interdigital space, but also to the area of the injury itself. But well, Atul, you just showed we should use the T1 to find a neuroma. So now you're talking about a pseudoneuroma. How can we differentiate that? Easy. The pseudoneuroma, it's gonna be not in the median aspect of the interdigital space. It's gonna be more skewed towards one of the quadrants. So in this case, we draw a line of the intermetatarsal space, and then we have four quadrants. You can see the scar goes way towards that area of the uh, of the MTP. So this means the pseudoneuroma pericapsular fibrosis. It's very useful to find a scar tissue, meaning chronic plantar plate injury. All right. And it has shown with great sensitivity, specificity. All right. And what about the indirect findings on MRI? Also, you're going to look for the interosseous tendon and collateral ligamentous complex if there is injury like tapering, thinning, or thickening or scar tissue. All right. And then muscle atrophy and fat infiltration. And of course, on the sagittal plane, the proximal retraction. When the proximal retraction is easy to see, that's okay. You have a large defect, but I just showed you a recess that can be a pitfall. So this study by some of my colleagues from Brazil have shown that if you have a plantar plate retraction in more than 0.275 centimeters, it's very specific for plantar plate injuries. But of course, there are some difference in acquisitions and protocols. So let's make it 0.3 centimeters, making it easier for everyone. Meaning below that, it can still be a normal recess. But above that, you should be very suspicious for a plantar plate injury. All right, so let's see some cases. We have a short axis view. We already see the tendon being subluxed medially, and then we see that there is something missing here. We see the medial aspect, but we don't see the lateral aspect of the plantar plate. And on T1, a lot of scarring and uh, and contrast enhancement right there. So let me go back to that pseudoneuroma that I was explaining to you. Uh, why pseudoneuroma? Because the neuroma itself, I just want you to make it clear that the neuroma itself it's gonna present at the median aspect of the intermetatarsal space, while the pseudoneuroma, the plantar plate injury, it's gonna show up more skewed towards the MTP, not in the very middle aspect. That's what I wanted to go back and be more clear. All right, so the first case we were seeing, and I'm showing a lot of contrast enhancement, which we already saw. It was easy to see the plantar plate injury on the short axis with a lot of scarring, the pseudoneuroma, a contrast enhancement. If we look closely, the collateral ligament is also torn there. Sagittal view, proximal retraction, large defect. You can see how proximally is positioned the plantar plate. And then see this edema, it's very typical. There is instability and the proximal phalanx this place will sublux dorsally. You're gonna have an overload to the metatarsal head and also biomechanical changes involving both sides. All right. So and over the time you can even find some insufficiency fractures due to this chronic overload without the plantar plate absorbing the impact. All right, another case, very similar, large defect at the lateral aspect, some contrast enhancement there, scarring there. It's effaced, proximal retraction, joint effusion, edema of the and bone edema at the proximal phalanx. All right, what about this case number 3 here? We see a defect both sides, medial and lateral, with a large defect seen on the sagittal and a huge proximal retraction. Another case, in this case, T2 short axis doesn't show too much of edema like we saw in the other cases. We see a lot of scarring. This is more towards a subacute to chronic case, different from the others. And this other one, barely no edema. We see scarring defect, proximal retraction, dorsal subluxation of the proximal phalanx. Radiographs, sagittal view, lateral views of the right side, weight bearing, lateral views of the left side, also weight bearing. You can see the hammer-toe deformity of that side. And then another case, a more chronic stage, lot of scarring, even some distension of the inferior recess of the MTP with fluid going between those planes. And we can see some joint effusion on sagittal. As you can see, this short axis, you can already tell the proximal phalanx is extended. The MTP is way extended. So you can tell these hammer-toe deformities on the MRI. Now let's move to our last part of the lecture today. I want you to remember another differential diagnosis for forefoot and plantar foot pain. All right. So we spoke about plantar plate injuries. I showed you the findings, both direct and indirect findings, and show you some cases. Now let's try to exercise some differentials to keep in mind if you see something like this that may become in your request as a neuroma or a plantar plate, but you need to be careful. One of them is the intermetatarsal bursitis. You're going to see fluid distension on T2 fat set. It can go dorsally, while the neuroma, usually you won't see going that dorsally, except if there is a intermetatarsal ligament injury, and then the neuroma will place dorsally. Intermetatarsal bursitis always correlate T1 with T2. T2 will help you to see the fluid. Post-contrast, if needed, you can see this synovial thickening. Even some tumors can arise as is a synovial tissue. We can even see some tumors arising at that area. All right. Next, differential Morton's neuroma. This is a classic one, and you can see how different it shows from the plantar plate. When it's even though it's large, you can tell it's right at the median aspect of the intermetatarsal space. Plantar aspect, median aspect. It's not skewed to one side or to the other side. On T2, some edema, you can see how thick is the interdigital nerve, but remember, use T1 as your best friend for neuromas, all right? And then sesamoiditis or sesamoidal fractures, they can happen due to chronic overload, especially in runners, all right? We can see not only edema of the sesamoid bone marrow, on X-ray, we can depict some sclerosis, and even sometimes, not in this case, some fractures, even though they're not spaced, they are very, very painful. And some cases, they even need to resect the sesamoid bone due to the pain. All right, plantar fibromatosis, we could see that in the we can see that in the mid-foot, forefoot, anywhere, usually along the plantar fascia, all right? Stress fractures, usually they happen at the neck and head junction. They do tend to have this transverse shape. Um, and sometimes on radiographs, they're not well seen. MRI can depict way much earlier and with clear image because the fracture line of the metatarsal necks are sometimes very thin and not sclerotic. We can miss that on radiographs, but remember that differential. Freiberg's infarction, which will be either a AVN slash insufficiency fracture. Why slash? Because there are different physiopathologies that can lead to this deformity of the metatarsal head. Over the time, in chronic phase, you're going to see shrinking of the metatarsal head with flattening and even fragmentation. So fibers infraction. Crystal arthropathies and microcrystal deposits. In this case, we see a classic gout deposits. It can happen in the lesser MTPs as well. And remember, synovitis can lead to degeneration and erosions of the capsule and even the plantar plate. All right, and last one, which we have been increasing the awareness of this common entity, is the plantar vein thrombosis or plantar vein thrombophlebitis. All right, these are more common than we think because sometimes we don't, if we don't look actively, we don't search actively for the midfoot vessels, we can miss them, and it's a common cause of pain in the plantar aspect of the foot. It can happen. It happens mostly to middle-aged or young patients with minor traumas. They do happen also with elderly patients, and they go. They have that classic appearance of a clot, a thrombus, and going along the plantar vein. It can happen either in the hind foot or the ankle area, but most commonly in the metatarsal area. All right. I think this was the last differential I had. Who wants to, if someone wants to read a little bit more about differentials of foot and ankle injuries, I recommend this paper that we also showed some 3D isotropic images that are useful for especially those tiny ligaments and the plantar plates. So this we have published recently in Skeletal Radiology. And another paper that very interesting, if you're gonna go further in your studies about the plantar vein thrombosis, there are two papers we have published last year. They are open access, and you can see some more. You can see some more findings on the plantar thrombophlebitis. All right, I think this was my last slides. I'm happy to take any questions, and I hope you have enjoyed the lecture.
Thank you so much, Atul, for the excellent and insightful presentation. I believe there is a survey link for the audience that will be posted in the chat box. Please fill that out so that we could get feedback from our webinar. Now we will open the floor for questions from the audience. Please feel free to type your questions in the chat or QA box. I can see that questions are coming. Let me go through the questions. There is one question from one of the audience. It says, "Thank you for great review. A useful finding for me is that in addition to subluxation on the short axis view is change in angulation of the lung cross-sectional diameter of the flexor tendon in cross-sectional, which usually parallels the bottom of the bone. Do you look for subtle change in angulation as well?"
I would say as an indirect finding, I would not be looking specifically for that. I try to focus on the plantar plate and direct findings, which are the defect and the retraction. And these indirect findings can help you access, especially more towards chronic cases.
Okay. There is one other question that was actually my question as well. It says, "Please explain the difference between pseudoneuroma and neuroma." And I believe this is my question as well, because to me, the term like Morton's neuroma is a most misnomer. Basically, it is a perineural fibrosis, and you propose another term, pseudo neuroma. Could you elaborate on that?
Yeah, sure. Let's elaborate that. That's why I also went back to the slides because I sensed that was not that clear. So let's start with neuroma. Like you said, neuroma is a perineural fibrosis. The interdigital nerve will pass right at the intermetatarsal space. So we are talking about the plantar aspect of the intermetatarsal space. We'll have the neuroma. Okay. Why pseudoneuroma came in the literature? Because it looks like a neuroma, it can be rounded and oval shaped, but it doesn't happen exactly at the median aspect of the intermetatarsal space. It happens closer to the MTP into the plantar capsule. It's very similar to the neuroma, but why is a pseudoneuroma? Because it's also fibrosis, but it's a pericapsular fibrosis showing a chronic plantar plate. The difference is that one is the right at the median aspect of the intermetatarsal space, the neuroma, while the pseudoneuroma, which is a name for the plantar plate chronic injury, it happens closer to the MTP in one of the quadrants.
Okay, so the way I got it is that the location is different. Is clinical management different as well?
I'm sorry, can you repeat that?
Is clinical management different as well?
Yeah, because one is a neuroma and another one is a plantar plate tear.
Okay, so you basically mean that what you mentioned, pseudoneuroma, which is using a misnomer inside the term, is related to plantar plate tear.
Exactly.
So it's always associated with the plantar plate tear.
Yes, pseudoneuroma is a name that came because it looks like a neuroma, but not. It's a plantar plate injury.
Okay, got it. One other question is about the plantar vein and artery thrombosis. The question is, do you see them with thrombophilic conditions or small vessel vasculitis? And my question is, like, can you identify these on like routine MRs that we get? If yes, how do you diagnose?
Yeah, so if they happen in thrombophilic conditions or small vessel vasculitis, I believe they can happen. But most of the cases, our last series, the series we published in the second semester last year, I think we had about 40 40 cases, documented cases, most of them related to minor traumas or chronic overload to the foot, and none of them had underlying vasculitis. And that was the first question. The second question is how to uh, uh, get that on image. Standard forefoot protocol, you're gonna see it because you're gonna see a vessel enlarged, the tortuous aspect, curvilinear aspect with edema of the vessel wall and the filling defect. The defect can happen either through the flow void, as you can see, or if you have the suspicion but you're not sure, go for a targeted ultrasound Doppler or MRI with contrast.
Mhm. Okay, okay. And there's one related question, and it's about using SWI to look for thrombosis. Have you used this, or have you seen anyone using this?
I've never seen using SWI, but I think gradient echo images and SWI might help if you so you can depict some hemosiderin. But I don't think they're necessary. If you have your standard protocol, you're gonna see. I like because thrombophlebitis is not a common thing to. It's not a common entity to think on the forefoot, and that what brought this idea for these papers we have published. We have many cases there presented. They are open access. You just type Taneja thrombophlebitis, and you're gonna see a lot of cases, so you're gonna get familiar to that entity.
Okay, great. Yeah, thank you. And one more question. It says, can these tears heal consecutively, or do they require surgical repair?
The plantar plate tears, it really depends on the activity performed by the patient. All right. We do have cases that are being treated surgically, even with arthroscopic surgery for small joints, with very dedicated and targeted approach from foot surgeons. But on the other hand, if the patient does not has a high level sports activity, or it, it, it can be managed conservatively.
Okay, great. And one other question I have here is about the steroid injection for these injuries. It says, do you get these referrals quite often? Is it a good practice to do it or not?
For plantar plate tears, no, it's not common for steroids to be requested, while for neuroma, we do that quite often.
Okay, great. Um, I have one other question. There's no more question from audience. I have
Sure.
one other question, and that's about use of contrast for
Mhm.
Terfto protocol. Is this routine in your practice? Is this something you
No,
recommend?
yeah, that's a good question, Majid. It's not routine in any of the practice I've been here in USA. It was routine of this institution I worked before, Albert Einstein Hospital in Brazil, because all the forefoots were done with contrast. In my experience, it's really interesting because especially if you have those subacute injuries or more chronic injuries, the contrast will help you depict exactly where the tear is, and it helps you to differentiate from the adjacent structures, even though in a very acute phase with a lot of edema. But I'll tell you that over the time, our learning curve has been increased. I mean, MRI qualities have increased so much that
Mhm.
the contrast is not needed. But the same question, let's translate the same question for, like, say, finger imaging of the hands. Uh, Contrast is not necessary for any of the finger imaging joint injuries, ligamentous injuries, and volar plates. But if we do have contrast, it's very interesting. We can clearly see the area of injury, where is there is a scar, where there is the defect. But it's not mandatory, of course. It's experience from one institution, and it's a large experience. And I do like, but I do not expect to have contrast in any protocol for forefoot if looking for plantar plate injuries.
Mhm. There's one question in the QA, and it's about 3D imaging for a routine. Is this routine for plantar plate tears in your practice or not?
Should 3D imaging be routine for plantar plate tears? It really depends on your capabilities to do a good 3D isotropic sequence. If you can do it, if you can do a good sequence with a good fat suppression, it makes sense, especially for the lesser MTPs. But also you need to consider that it's if you're gonna add a 3D sequence, you're gonna spend more. The patient will spend more time in your scanner. You're gonna need a longer slot, or if you are willing to replace a sequence for a 3D one, which I think we're gonna get to that point at some moment, um, you need to be careful that you have a very good quality, and your especially your requesting physicians are aware of that. You're going to replace, let's say, a T2, two planes of a T2 for a 3D image. Then it makes sense, so you don't have a longer exposure of the patient, longer slots, and more time consuming. I don't see 3D imaging as a routine, as a replacement for conventional sequence yet. I do see institutions using 3D in addition in an experimental phase.
Mm-hmm. Yeah, and I can elaborate on that as well.
Sure.
In my practice, we have shift all the terto protocols on 3T because we
Mm-hmm.
believe it has like better signal to noise ratio and tissue contrast. And also we have 3D isotropic imaging on all of those. And we have found it very useful. The slice
Good.
thickness is 0.1 1 millimeter isotropic.
Yeah,
And I believe it adds value when you want to evaluate those smaller structures, including plantar
I agree.
plates.
I
Um,
agree.
and yeah, no, that was great. It generated good discussion around it. I don't see more questions in the QA. I personally don't have more questions as well. And if there's no more question, I would like to thank the audience and our speaker. I also want to mention that the next Resident Education Club webinar will be on December 10th. The presenter is Dr. Philip Wong, who will talk on introduction to traumatic brachial plexus injuries. And with this, I believe we're done with this webinar. Thank you for your attendance.